And then it's over to, oh no, I haven't spotlighted you. That's the only thing I haven't done. Hang on, here's spotlight for everyone. There we go. All right, I'm going to open the lobby up now. Here we go. People are coming in. Excellent. So we're just going, welcome everyone. It's now the afternoon of day 4 of our Wellbeing Week.
You're almost there, Kim. You're almost there.
We've had Hub Day yesterday, yes, and we are now heading on the downward run. So many great sessions that we've had. A wonderful session this morning with John McLean, who is a inspiring man. If you get a chance to watch if you're a member organisation, a chance to rewatch that session. It was a wonderful conversation between Stephen Worrell and John about his story, and just, incredible story of resilience, and how he just keeps doing amazing stuff, like it just doesn't never stops. So if you get a chance to watch that. Yesterday we had wonderful Dr. Nick, who's on the call with us now, also doing a session. So many things to watch. So make sure you go back in if you have missed sessions this week, and you can watch those for the next 30 days. So I might just, looks like we've got a few people in the lobby. We might just get started, and we are recording. So this recording will be available for everybody as well for the next 30 days. And for those that are joining external to our member organisations, we will send out an email with the recording link for you. All right, well, without further ado, for those that don't know me, I've been on many sessions, but my name is Kim Hamrosi, and I'm here from the Corporate Mental Health Alliance. We're a business-led, expert-guided organisation, basically an alliance of sort of 20 plus large corporate and small corporates across Australia. It's really great to be here with you today. And we know the reason we've created this week, because it's all about creating space for all of us to spend time to reflect, reset, and to support our mental health, both at work and beyond in our lives. For those that would like to know more about the Alliance or access our wellbeing resources, you can scan our QR code above me. And you can visit CMHAA.org.au as well. Before we kick off, I want to also say a big thank you to Metaluma for today's session and for making time for us and offering the wonderful Dr. Nick to share her knowledge and wisdom with everybody. You make these conversations possible, and so it's wonderful, and I'm really pleased to introduce you today. And so for those that don't know, Dr. Nicole Arvard is an integrative general practitioner at Metaluma with a special interest in women's health. She's very passionate about making sure that she's walking alongside women through this menopause transition and offering evidence-based holistic care that supports both their emotional, hormonal and physical well-being during a significant life stage. I think today's session is going to be exciting too, because it's what men need to know. And I think that's going to be helpful for so many men. I hope some of them have joined, or for women who want to share this later on with their partners, you're very welcome to. So please, Nicole, you could be with us, and I hope everyone enjoys today's session. Please welcome our speaker. Feel free to use reactions. We've got the reactions. Use the chat for comments, questions along the way. We'll do our best to get to those. Certainly sometimes during the conversation, but maybe towards the end we'll have time for questions. All right, over to you, Dr. Nick.
Thanks, Kim. Thanks, everyone. Thank you so much to the Corporate Mental Health Alliance for inviting Metaluma and myself. It's when I was talking to Kirsten and Kim about this week, I'm like, well, I don't think we can do mental health, particularly for women, unless we put a hormonal lens on it. So it's really exciting to be here. And thank you so much to all of you guys for showing up in your lunchtime. I always say we heal best in community, and all genders are needed in our community to help us heal. So I'm really, really pleased and privileged to present to you today. What we're going to do is we're kind of going to do a bit of a whirlwind around the grounds of what the menstrual cycle looks like, what happens when it looks different, and how in particular that can impact mental health, and then a high level kind of review of menopause with some action points at the end. So thank you so much. Before I jump in, I am coming to you from Darkinjung land today. There is an acknowledgement of country in the chat. I'd like to acknowledge First Nations people and the care they give our land and community, and any particular First Nations people on the call today. Also want to acknowledge that when I'm using the word woman in this presentation, I'm referring to assigned female at birth. I know not all people assigned to female at birth identify as women. We're open to a range of experiences. So where I want to start is basically at the menstrual cycle and what it looks like when it's running kind of smoothly. So for a woman, the first day of her menstrual cycle is day one, and that's when she's starting to bleed. And most women will bleed lightly to moderately for about 4 to 5 days, usually with no pain. And the reason I say that is that having a painful menstrual cycle is actually not a normal experience. It's a common experience, but it shouldn't be normalized. And I think that's the first thing to take home from today, is that the society has normalized painful, heavy periods, and that really should be looked at and investigated. Once a woman bleeds, then she moves into the follicular phase, which is where the lining of the womb starts to grow. That's where estrogen is rising. And then what happens is there's an LH surge, which pops out of the pituitary to tell the ovaries to drop an egg. It's that LH surge that's important, because that then gets the ovaries to change to secreting progesterone, so that progesterone can grow the lining of the womb really thick, and ready for a pregnancy. And then obviously if a pregnancy is not received, then around we go again and bleed. The reason why I tell you this is that as we're going to unpack, as it looks a little bit normal, those particular phases around the follicular phase where estrogen is rising and the luteal phase where progesterone is rising is important for when it looks a little bit different. So what does it look like as we're transitioning across our hormonal life? Women actually spend 40% of time in some kind of hormonal transition across our lives. So it can be a lot to navigate. So basically there's puberty when we're hitting our first menstrual period, and then we move towards, if you're choosing to have babies, pregnancy. And then we're moving after pregnancy into our early 40s and mid 40s into perimenopause and menopause. Now, menopause is one day in a woman's life. It's exactly 12 months after her last menstrual period, and it represents a cessation of reproductive functioning pretty much. In Australia, the average age for menopause is 51. If you're of Middle Eastern or Asian populations, then that can drop to 47 or 48. So this is the time where we're starting to talk about menopause. But the bigger area we're also interested in is perimenopause, which can happen for up to 4 to 10 years prior to that last day in your menstrual cycle. And we'll jump into that a little bit later about what the symptoms are. So what does it look like if things are looking a little bit different in that pubescent coming into pregnancy phase, which for most women is in our teens, 20s and 30s for some? So puberty can look a little rough. It's a little bit like menopause, but at the other end. So remember how I said there's that LH surge? Basically, what's happening is we're starting to ovulate, and as we're ending to ovulate at the bookends of our cycle, is that LH surge is really quite erratic. So that means that there's not a nice, smooth cycle happening with estrogen and progesterone. It means that estrogen can be fluctuating, and at pubescent phase, progesterone is starting to rise, and at menopause phase, it's starting to drop. And it's that fluctuation of estrogen and progesterone that can make puberty, so that teenager area, really quite tricky if there's hormonal plays coming into mood. Well, how can it look different for other presentations? So polycystic ovarian syndrome, that's a syndrome which is essentially defined by periods that are irregular, so periods that are generally longer than 28 days in cycles. Could be 30 days, could be 40 days, could be sometimes 60 or 70 days. And that's because that LH surge is happening less. So there's what we call an ovulatory cycle. So ovaries aren't dropping out of the eggs are not dropping out of the ovaries to get that, again, that nice smooth hormonal cycle. And it changes the hormonal regulation. And what can happen is women can start to put on weight, particularly in their teens and early 20s, and they then shift into what we call testosterone excess. So they can have very long irregular periods, starting to gain weight, and then the testosterone excess means that they can grow hair where they really don't like it. So on their face, around their nipples, down their back, it's heavy growth on their inner thighs. So that PCOS picture is really important to start to recognize early, because those women are at risk of infertility. They're also at risk of insulin resistance and early diabetes, and diabetes through pregnancy. So it's just something to be aware of if your loved ones are experiencing changes in the menstrual cycle or similar symptoms, just to think about getting investigated. What is PMDD? So premenstrual dysphoric disorder is a syndrome where it's a Jekyll and Hyde syndrome. So women can feel like they're living their best life in that follicular phase, so that's 0 to day 14. And then there is a shift in progesterone sensitivity. So progesterone acts on the brain on the GABA receptors, and it's really quite calming. But in PMDD, there is the opposite effect. So for some reason, there is a change in progesterone sensitivity that causes the GABA receptor to become excitatory instead of calming. And it means that there is a Jekyll and Hyde kind of situation. Can be really quite upsetting for women, where they're feeling quite well through that follicular phase. And as soon as they ovulate, they can get ragey, irritable, mood can drop, anxious, depressed. And it's a bit more than what we call premenstrual syndrome, where if you're a little bit teary and a little bit irritable 2 or 3 days coming into the cycle, that's premenstrual syndrome. But PMDD is a DSM-5 diagnosis where there is really quite a stark difference. And for women, it's 50% of your life to live and try and manage this significant hormonal change. So again, I'm bringing this up because if you know someone that's experiencing that, it's not normal, and there is help out there. And we're not to normalize that these significant mood changes are just bad PMS. And lastly, a passion point of mine is endometriosis. So endometriosis is a diagnosis that can be quite debilitating. It's often diagnosed late, like 5 to 7 years after a woman presents with her first symptoms, again, which is why I'm popping it into this presentation here. It's where the lining of the womb sits on the outside of the womb, but it bleeds just like the lining does every month. But because it's on the outside of the womb, it's bleeding into the pelvic cavity. So that means women can suffer from significant pelvic pain with their period, painful intercourse, heavy bleeding, mood changes, insomnia, and it can happen outside of the period as well. So they might get pain at ovulation, they might get changes in their bladder and bowel function at the time of the period. So again, painful heavy periods is not something that should be normalized. And if you know someone who's experiencing such symptoms, then having conversations around could it be PCOS or PMDD or endometriosis with their medical practitioner is really important, so they can get the accurate diagnosis and then subsequent treatment. Endometriosis, there are a lot of treatments available, and we'll dive into what they may look like now for those different things. So what I've put, sorry for my typo there, I've got primary dysmenorrhea. So dysmenorrhea is the medical term for period pain. So primary dysmenorrhea means that you have period pain and we can't find a reason for it. So you are sensitive to period pain. And again, that is something that shouldn't be normalized or put up with or suffered. And there are treatment options out there like non-steroidal anti-inflammatories, particularly Ponstan, or the combined oral contraceptive pill and magnesium that can help with primary dysmenorrhea. Having said that, primary dysmenorrhea is always a diagnosis after secondary dysmenorrhea, so causes for painful heavy periods has been excluded, and that might be ovarian cysts, endometrial polyps, endometriosis. So it's important to get your loved ones assessed, as I say. PCOS is generally treated with a focus on exercise and diet. So we want women to be shifting towards a low glycemic index diet, exercising as much as they feel they can. There are also medication options around the combined oral contraceptive pill to regulate their period and reduce their cancer risk, and treatment options for hair growth and fertility. Premenstrual dysphoric disorder, again, can be treated with certain combined oral contraceptive pills. There are pills that are a bit more what we call body identical that often sit well in this space. And it's the one condition where SSRI medication, which is usually medication that's prescribed for anxiety and depression, can be used just in that luteal phase. So just for that 10 to 14 days that can feel really uncomfortable for women, they can actually go on and off that medication if you have a diagnosis of premenstrual dysphoric disorder. And lastly, endometriosis is a little complicated. It definitely requires multidisciplinary care. I usually work with my women with dietitians, with exercise physiologists, with pelvic floor physios to help with pain, sensation, and then a gynecologist in terms of what are the treatment options there around hormonal suppression, sometimes surgery and fertility support. So you can see that if it runs normally, it's amazing, but for a lot of women, it doesn't necessarily run normally. So that's a kind of a round the ground look of what it can look like when it's not running to as smooth as what we like it, what the diagnosis may be, and how to start to bring those conversations up with medical practitioners, because there are solutions out there for women if menstruation is problematic. What about pregnancy? So if we're choosing to get pregnant, then we move into a very high estrogen and high progesterone state. And if you're generally not affected by nausea and vomiting in pregnancy, a lot of women will feel tired in the first trimester of pregnancy and then really feel quite great through the rest of the pregnancy because of the high estrogen and high progesterone state. Once the bubba's born, there is a sudden drop in estrogen and progesterone. And that can have an impact on mood. It can have an impact on a whole range of things. It can look a little bit like the perimenopausal phase. So sleep can be disturbed, in excess of having a new loved one. You can feel a little bit more anxious or on edge. You can get vaginal dryness and vaginal irritation. And then you wrap around that the fact that stress is also a little bit higher because you've just been thrown into a world that's completely new. Then again, it's really important that we're making sure that our postpartum women are aware of the mood changes that can happen and we're offering support. So I think, once again, we heal best in community, and ensuring that there are social supports, whether it's family or friends for new mums, to whether it's practical support with a meal train or sleep support or just being there for a conversation, I think is a big thing that I get passionate about for supporting our new mums. There are other supplements out there that can help with what we call postnatal depletion, where because often they're breastfeeding a human, that human is taking a lot of nutrients, and that the mum can be sleep deprived and often not eating well herself. So things like omega-3 can help with brain function for mood, making sure iron and thyroid is okay if a mum is struggling, particularly with energy. And not to forget that the drop in estrogen can affect the vagina, so that the vagina can feel really irritated and dry, and return to intercourse can be quite painful. So this is a case where postpartum women can use vaginal estrogen in order to get more comfort around vaginal symptoms if they're suffering with that after pregnancy. So just to refresh, we've kind of moved through, puberty and what a normal menstrual cycle looks like, at a very high level of what it looks like when some of the common things that can happen when it's not running to schedule. If you get pregnant, what happens with the hormones then, and then after you're pregnant, how they tend to fall, and the pregnancy affects different systems with the hormonal changes, the post-pregnancy time. And then after pregnancy, we then tend to move towards menopause. So as I said, menopause in Australia, the average age is 51, but that perimenopausal transition can be up to 4 to 10 years before that. So we really need to be having perimenopausal conversations with women definitely in their 40s, and for some women even in their late 30s. And if you think that you've come off a baby in your mid 30s and then very quickly you might be perimenopausal, it can feel a little bit overwhelming. So just remember that the biology of the perimenopausal period is that estrogen is fluctuating quite a lot, and as a general rule, progesterone is declining. Testosterone is also declining, but testosterone starts to decline for women roughly in her mid 30s. And that can contribute to a whole range of symptoms well before the menopausal day, which is that day after a woman's last menstrual period. What are these symptoms? So here at Metaluma, we've developed what's called the UMA 40. So the UMA 40 is a blend of what we call the green climacteric scale, which is a very old physical representation of the perimenopause and menopausal symptoms. And we've blended that with the Meno-D, which is a specific screening tool for menopause depression, because menopause depression looks a bit different to standard depression and anxiety. It's a bit more fluctuant. It can be more intense with the insomnia and the rage and the anxiety. So what we've done with this UMA 40 is we've worked with the HER Centre at Monash University to turn it into a digital tool so that women can start to connect the dots if some of these symptoms are potentially perimenopausal or menopausal for them. Of course, we need to make sure nothing else is going on. So we would always say, check in with your doctor to exclude other causes, because again, we don't want to go to the other end of the spectrum and say, oh, everything's due to perimenopause. We want to make sure that things are being excluded, like low iron or thyroid disorders. But basically, we break the symptoms into three broad groups: the physical ones, the cognitive and emotional, and then those not spoken about. I'm going to focus on the cognitive and emotional in the next slide because that's clearly relevant to Corporate Mental Health Alliance and how hormones are affecting mood. But the physical ones, most people think of menopause as hot flushing. It's actually not what I see walking through my door. Yes, some women are hot flushing, but it's not what they come to me about. They will come to me because their cycle is changing. It's getting more frequent. It's getting more heavy. It's getting more painful. They're getting breast tenderness. They're putting on weight. They're getting increasing headaches or migraines. They're getting joint pain, particularly in their shoulder, in trochanteric bursitis in their hip, plantar fasciitis in their feet. They're generally feeling tired and they're not sleeping. So that kind of waking at 2, 3 a.m. in the middle of the night, independent of hot flushing, is often what I'll see women presenting with. And it's at a time where they're really busy. They could be parenting up to aging parents, working full time, raising children, and often they're putting it down to stress and just soldiering on. But the UMA 40 helps connect the dots to say, there might be a hormonal play here and we need to think about that. I'm going to jump to the end of it, and it's important to speak to your partner if you feel comfortable enough around the symptoms that could be affecting the genitourinary area. So changes in estrogen and then a drop in estrogen and progesterone means that the vagina gets dry, it gets irritated. Women often have to run to the toilet frequently. Intercourse can be painful. There can be irregular vaginal bleeding. So when you're blending a bunch of physical symptoms, changing body shape, potentially with genitourinary symptoms, of course, libido can drop, and there can be many factors to libido dropping for women in the perimenopause and menopausal time. And then the thing that we get really passionate about, which is why I'm so delighted that Kim asked us to speak, is the cognitive and emotional impacts. And women are often just put down to being anxious and depressed when it's actually a hormonal play, and we need to be giving them hormones to help with their symptoms. There is generally a rising anxiousness, as I commented. There is waking in the middle of the night. Brain fog is significant, just forgetting kind of names, forgetting words that you can speak. That was a good I can't even think of the word. That was good. I've got brain fog myself. So it's the brain fog, not being able to think of words, depression, lack of confidence. And I often see that women actually just lose a sense of themselves. And this is at a time where they're often in, the peak of their careers and a lot going on in their family lives. So this slide is why I'm so delighted that you're here to speak about women's health and hormones and the impact on mental health, is because if you've had a history of anxiety and depression in the past, you're going to potentially struggle through the perimenopause and menopausal phase. If you've had a history of postnatal depression, you are much more likely to struggle through the perimenopause and menopausal phase. As I said, 40% of women are presenting to GPs purely with anxiety and depression symptoms. They're often given SSRIs, which may well be appropriate, which is medication to treat anxiety and depression, but really we have to be putting hormone replacement on the table as a conversation here. And sadly, that last circle is one that still brings tears to my eyes every time I present it, is that the completed suicide rate for women in Australia is highest at the age of 45 to 54. So thank you for showing up to start conversations around menstrual cycles, how it could look different, and particularly perimenopause and menopause for our women, because we need to be all in this together. And then there's the workplace. So, beyond all of that, these women are soldiering on and suffering at work. So there's a dearth of research on the impact of menopause for women in the workplace. There's some out there and we're getting better at it, but one study showed that 50% of women said it would affect their performance. 40% would take more sick leave, but they wouldn't say that was the reason they were taking sick leave. 26% reduced hours or a promotion, and 10% leave the workforce accordingly. When you look at the Australian Bureau of Statistics in terms of gender pay gap, there is a stark difference that starts to happen about the age of 45 between men and women reducing their time in the workforce. We don't quite know why. It could be caring responsibilities, but one has to postulate that it's potentially because of perimenopause and menopause, and they don't have to suffer. We can do something about improving that. And I won't dive into the big kind of conversation around MHT, but ostensibly the landscape around MHT has shifted significantly. So there was a big study in 2001, which showed that hormone replacement therapy was essentially dangerous. It took one type of hormone replacement therapy that we really don't use anymore and gave it to an older cohort of women, and then misrepresented the breast cancer and cardiovascular risks and generalized that to basically the population and spread it all over the world. And subsequently, hormone replacement therapy prescribing just fell off a cliff. In Australia, the name has changed now. It's now menopause hormonal therapy to get rid of the word replacement. And the pendulum has swung way back the other way. We've done more research in the area. We've changed the way in which we deliver MHT now. So it's body identical, so aligned with your hormone, the same as your hormones. And we know it is the best thing to reduce symptoms, 80 to 90% reduction in symptoms. The Her Centre did a study that showed 60% improvement in mood when women were started on MHT. I see improvement in sleep, in mood, in cognition, in joint pain, in hot flushing, in cycle regularity, in libido, in urinary symptoms. We know that it's protective for bones, so it's going to protect women's bones and reduce their fracture risk. If it started in the first 10 years after the menopause day, it actually reduced cardiovascular risk, so less chance of having a heart attack or a stroke. We think it might help in dementia reduction. The studies are still a bit emerging over that with the new formulations of hormone replacement and how they're moving into cognition for women in their 70s and 80s. So many benefits for MHT. And if you can't take MHT, there are other things we can offer women for symptom control and other prevention over this time. The risks are pretty minimal. So there is a small increased risk of clotting, but if you deliver the estrogen, what we call transdermally, so across as a gel or as a patch, then that risk is negated. And a very small increased risk of breast cancer. Quotas is about 1 in 1,000 women over 5 years if you're taking estrogen and progesterone. If you're just taking estrogen as hormone replacement, which women can do if they don't have a womb, then their breast cancer risk is actually reduced. So that's kind of the high level MHT of supporting women through perimenopause. But what can you do as a guy for loved ones in your life? So first and foremost, educate yourself. So thank you so much for showing up to this talk and learning about what a normal menstrual cycle looks like for your wife, your loved ones, your daughter, how it can look different and how you can have your spider senses up around whether someone needs to, get further support, and particularly what it could look like in terms of perimenopause and menopause and those symptoms, particularly the ones around genitourinary health, libido, and mental health, because it's so much bigger than hot flushes. I'm a big fan for starting conversations. We only get better at awkward conversations by having awkward conversations. And I know my gorgeous husband and I, we have this thing where, he really wants to help me and solve my problems for me if I'm suffering. But sometimes I just need him to kind of listen and hold space. So we just kind of do this banter around it. Do you need me to solve this for you? Or am I just holding space, and you'll kind of work it out yourself? So, starting open conversations is really imperative with your loved ones. And if you're a leader in the space, thinking about how you might be able to, depending on your organizational culture, start to educate your team around these issues, to build a supportive culture and even potentially flexible work environments that are supporting women, that, if they've got flooding, heavy, painful periods, could they potentially work from home? Simple things like that may not be simple for an organization, but, that could potentially support the myriad of changes that may happen to a woman across her hormonal and menstrual period. You are leading by example because you've shown up to this talk and you're educating yourself. So thank you very much. I've kind of been over that, tackling conversations, whether it's as a partner or as a leader. Women can, I'm just going to call out that as a leader, women can often feel, as I said, really low self-esteem, changes in their body they're not understanding, lack of confidence, even guilt and shame. So these conversations can be really quite sensitive. So starting from a strengths-based conversation and a place of empathy and care to seek to understand before getting solutions can be really quite helpful, because every experience is different. There is not one universal experience. It's very individualized and personalized. But as I said, awkward conversations only get better by having awkward conversations. And the fact that you've shown up is just amazing to inform yourself on how you might start to have those conversations for your loved ones or your colleagues. And I think that's it. What to do for your loved ones. So first and foremost, if you think there is an issue going on with the menstrual cycle, encourage someone to get assessed by a medical practitioner to make sure they're not just normalizing what could be a heavy, painful period, or there's not other things going on. If you or your loved ones or your colleagues, if you have someone who you think might be moving through the perimenopause and menopause transition, then that's the QR code to scan, and that will take you to the UMA 40 where they can assess their symptoms. And if they want, they can reach out to Metaluma for help, or their results will come to them. If they have a trusted GP relationship, then certainly take that to their GP to have a conversation around perimenopause and menopause. And then just think about how you might start conversations for yourself with your loved ones, your children, your friends, your colleagues on any of these areas that you might see kind of creeping up in your life. And that's me done, I think. Kim?
Thank you. That was
did we get to the end of the slides without it freezing?
We did today. We
Awesome.
did today. There's some reactions there. Please say, thank you to Dr. Nick once again. And this recording is available. We do have some time. If anyone has any questions for Dr. Nick at this point, if anyone wants to ask anything in the chat, feel free to do so. We would be very delighted to answer those questions. I do have a bit of a question around the conversations for men. What should they know? What not to say? I think is the biggest thing. Is having been that with like, oh, you're a bit of a nightmare at the moment. It's like, well, yes. I know I feel a bit stabby right now, but you can see it yourself. But what are the sort of things that may be a good way for men to think about starting that conversation? with
Yeah.
even
Look,
with
I think I
actually
feel
in the
like,
workplace maybe is probably
yeah.
the more.
I mean, I feel like the mere fact that that you guys have shown up, you probably know how to start those conversations because you're interested. Um, but I guess I will raise the point that, as I said, women are often feeling already terrible. It's like we have insight that we're being an asshole and moody, but when it's hormonal, you just can't get yourself out of it, and it's really uncomfortable to then to have someone reflect that back in your face is confronting and only going to create a defensive response. Um, so, so I always start awkward conversations from the I, like I can see, I've noticed that you're struggling a little bit. How could I help? Do you want to share? You know, I'm here. I've got an open door if you want to share what's going on for you. I, I guess you got to judge the person if you feel
Yeah.
like you want to bring up the perimenopause or menopause comment, as opposed to just going, are you sure you're not menopausal? Because that's like that could again just be like up yours. So yeah, it's individual, but I guess it's coming from a placing, like I said, coming from a place to seek to understand what the person's experiencing, because it may not be menopause, there may be something else going on, right? So yeah, I would say seek to use open-ended questions, listen, seek to understand with empathy.
Excellent. And also too, we're well done to so many companies that have already supported like things like menopause leave, or they've put in, products in bathrooms, or provided, we know, like training within their own organizations for not just women, but for men. When I say
100%.
training, I say educations, but
Mm,
there's a lot of companies can't afford to do this.
no.
And today what you're providing on a wonderful free session is awesome. But where are some other? I know Luma's got some fantastic resources, but where are some other places that women or men or whatever can get just resources themselves, just some other options if they're
Yeah, so
looking around, and what are good sites?
yeah, great question. So Australian Menopause Society is probably your best one to go to. So they have a wealth of both consumer and professional health information sheets on every topic imaginable. And they also have a list of doctors that are trained specifically in menopause, because as a GP, we're meant to know everything about everything, and our scope of practice is becoming broader and broader and with less and less time on our hands. So unless you have a particular interest, it's really hard to stay up to date with everything. So it's not GP's fault if they don't necessarily know this. They just might be really invested in another area of interest. So if you find that the medical professional is not gelling with you over the symptoms and what's happening, then find someone else who might have that interest. And the Australian Menopause Society is a great place to start for that in terms of medical professionals.
So,
And you're right, it's a great point that some corporations can't afford that. But even, I mean, first, we've been working into corporates, and I'd have to say the biggest game changer is just a safe space for women to be listened and validated can go thousands of miles, and that's free.
yeah, it's a very good point. Actually, we don't always have to do whiz bang things. You're
No.
right. It's just creating a space for the conversation to occur, like what we're trying to do today. So, you're
I
welcome if
think
you're.
I was going
Sorry,
to
go
say,
ahead,
did
Dr.
Troy have a question, or did someone have a question? Or
So Rudy has just made a
ah,
comment here, just as a husband, when my wife goes through a rough time, I'm not sure what I can do, but that's
yeah, it's hard, Rudy, isn't it? I know my husband thinks that too.
um,
Oh,
but I feel like everyone's a little bit shy today. We had lots of conversation yesterday. I wonder if men are worried about saying the wrong thing. But I guess as a man, for anyone, males on the call, is there something that you might stop you from speaking up, or from asking questions? Is there, is it asking you what would help you to be able to have these conversations? If anyone's brave enough to put anything in the chat, that would be good. And we've just, Kelly, we've just covered the good online resources I may be able to direct my husband to, so he can be aware of why I am not myself. Australian Menopause Society. At the end of this chat, at the end of this session, on the Hey Summit platform and on the email that goes out to those that are joining, we will put a couple of links to those resources and to the MetLuma site. So again, Australian Menopause Society, and please have a look at the site, which was a QR code before. Any male brave enough to put something in the chat?
A good turnout in the lobby. That's great. Yeah.
Yeah.
I think
What
it's
have you found in your research actually about, because I know you have done some sessions with men along the way. Is that correct in some of the research you did?
some of our best sessions have been with men, I'd have to say. And I think the reason is that when you bring that balance of empathy and listening with the male, say the male kind of, really logical skill set of problem solving, like it can go a really long way in some solution-based environments. So I've heard a lot of the things that, like that Rudy said. I don't know how to support my women. My wife, I don't know how to start the conversation. I don't know how to bring it up in the workplace. Like these are all very, very common scenarios. And I guess my answer to that is there's no one answer to that. And the first thing is that you know that you're not alone. Every human is going through this at the moment, and we only get better at this space by leaning into the edge and staying curious and having the awkward conversations. And sometimes that's how I start the awkward conversation. I'm like, look, this is a new space for me. I've been learning a little bit about perimenopause and menopause, but I don't quite understand it and how it may be impacting you. Can you help me understand what your experience is of that? So if you're always coming from a place of compassion and curiosity, sometimes it might get mucked up, but a lot of the time it doesn't. The other thing I would say is that pick your timing. Like when I get home from work at 7 o'clock at night, that is not the time for me to be having that conversation with my husband. Like he knows that he's not going to approach that with me then. Saturday morning when I've been for a swim and we're walking along the beach, like that's when then I can be more connected with those conversations. They would be my tips, I guess.
Awesome. We've had a male, I think, Bruno. I
Thanks,
think Dr.
Bruno.
is very informative. As a man, I was very keen to hear from you about this subject. I will share some insightful tips to my sister, who is now 48, and some female friends in their 40s. And of course, with some mates so they can all learn as well.
Yes.
Well, thank you, Bruno, for posting that in the chat.
Yeah, start to bring menopause up in your pub chats. I think I co-host with Greg doing some webinars into corporates, and he started to bring it up in his I think he does salsa dancing with his other male compatriots. He does he says it's like a bingo card of like responses where everyone's like, oh, not talking about that, to right up the other end. We're like, oh yes, let's chat about that. My wife, blah blah blah. So we as a generation, we're getting better at those conversations.
Actually, I've got a couple of things. The UMA40 symptom tracker doesn't cover all countries. Why is it limited to only some countries?
Oh, great question. We're working on that. It's work in progress. So it's obviously we're working through a translation piece. So it's in Switzerland at the moment. It's in Portugal. We're about to launch in South Africa and Taiwan. So watch this space. But great question.
Awesome. And last one step before we wrap up, I think, is there anything that should be done before it starts in early 40s? Like I know that there's a variation.
Great question. Yeah.
What should men and women perhaps thinking about for both of that?
Yeah, so I think it's a bit of the fun police stuff. I think the biggest thing is because the changes in estrogen will change insulin metabolism, which means there can be a slow creep of weight gain. So drinking excess alcohol, not moving enough, eating excess carbohydrates in the late 30s into the 40s, and with that slow creep of weight gain, both for men and women. Once women are hitting their kind of late 40s, early 50s, it's really hard to get that off because of the estrogen loss. It can happen. It's just it's harder work. So you've heard me say this before, if I could mandate anything as a public health physician, I would mandate enough time for people to move their bodies. So think about how you can have a relationship with exercise that's going to be sustainable moving into your 40s and 50s, because if you build muscle, that's going to help with your insulin resistance. Women will lose muscle in their late 40s, moving into their 50s. It just puts your whole metabolic health and your bone health in good stead before you're hitting it.
That's some really good advice. And often we forget about the really basics of enough rest in terms
That's
of
right.
sleep,
Sleep.
and, you know,
Yeah.
moving, just because we are becoming so sedentary in our
It's
jobs, is just
hard.
getting up
Yeah.
and moving every day such an
Yeah.
important part.
Yeah, like if I won't hit, 3,000 steps if I'm in the clinic, so I have to be really conscious around monitoring my movement and making sure I'm getting enough movement in. But your sleep's a good one. You heard me say it yesterday. It's
Yeah,
really hard to move if you're not sleeping because you're exhausted. So
yeah.
sleep and then try and move.
And then nutrition, I guess, is the other side of it, where you see a changing, where your body changes. You don't need as much food as you get older, and we still seem to think that we do. So how do you kind of think that through as well? And
Yeah,
there is, I guess, there's a lot of conversations now around women, different sorts of diets for women in their 40s, 50s, menopause, because of the changes of insulin and all that. So
that's right.
it's a
Yeah.
whole other topic we
Yeah,
could
I
go
could get me
into,
back
Doctor.
next year and we can do that one.
We would be delighted to. So thank you, everyone, for
Always a
joining
pleasure. Thank you
today.
so, thank you so much, everyone. Such a pleasure. Thank you for coming along.
Thank you, thank you. And everyone, enjoy the rest of your day. There's still a few more sessions at Wellbeing Week for those in their member companies. This recording will be up and sent out over the next couple of days. So thank you, everyone, so much. Have a great day.
Have a day, great day. Bye.